Okay, well, welcome everybody. I'm Laura Clark. I tend to be behind the scenes here, but I'm a PA in the Center for AIDS Research Clinical Core, and Eileen happens to be at the National CFAR meeting today that's happening before CROI, so she won't be with us today. So I'm going to introduce our speaker today. Rich Ambinder probably needs no introduction for most of you. He has spent his career in oncology here at Hopkins. He treats lymphoma. He's an expert in Kaposi sarcoma. He researches virus-associated cancers. And I've had the pleasure of working with him for about the past 10 years, supporting his HIV-related research, most of which is done through the AIDS Malignancy Consortium, which is a national consortium of oncologists. So Rich is going to talk to us today, giving us an overview of lymphoma and Kaposi sarcoma in people living with HIV. Rich, and you can share your slides.
Yep. So thank you for the invitation, and thank you to Laura for years of support, and to the CFAR for supporting me and collaborators, but also supporting Laura in her helping with our endeavors. No disclosures. I wanted to start out telling you a good story about brain lymphomas, primary CNS lymphomas, and mentioning that when AIDS was first recognized, it was in part because brain lymphomas were extraordinarily rare in the general population, but started appearing in people who had other AIDS-defining illnesses. And that's sort of when my career started as well. I'd been working in the laboratory and found a new approach to identifying EBV in tissue specimens. Up till that time, it had actually been fairly difficult. Justin MacArthur, who was not yet the leader of neurology, had arranged for an autopsy series of HIV patients who died at Hopkins, and he collected 172 autopsies and found that 19 of them, 11%, had primary CNS lymphoma. We tried the new technique on these tumors, and you see them staining darkly in this brain tissue, and all 19 were positive for EBV. In the general population, it's rare to find EBV in a primary CNS lymphoma. And the treatment for HIV and for primary CNS lymphoma was dreadful back in the day. I actually led the only national cooperative group study of the treatment of AIDS primary central nervous system lymphoma. And it says something about the patients who get this, that the median CD4 count was 10. So a really, really sick group of patients. And our therapy probably didn't have any useful impact. Almost everyone died quickly. And often they died with infections related to their immunodeficiency, but if not, they certainly died of their lymphoma. The world has changed in many regards. With antiretroviral therapy, the incidence of primary brain lymphomas in HIV patients has fallen dramatically. In people without HIV, there are complex new regimens that have much better results than in the bad old days. But typically, involve many months of chemotherapy followed by high dose therapy with an autologous transplant. And even then, there are some late relapses. Um, it looks to me, but again, there are no national studies, that HIV patients with fairly simple chemo regimens um, are regularly achieving complete remission, and I haven't been taking them to transplant because I haven't seen any relapses. Um, this is a table of the rising incidence of primary CNS lymphoma with HIV, and then the fall, and you can see the study ends in 2005, but the fall has continued. So primary CNS lymphoma in people with HIV is curable with modern therapy. I'm sure that antiretroviral therapy has a lot to do with this, and probably explains why I believe we're seeing better outcomes with HIV patients than in people without HIV. I think the ability to restore immune function is probably what's preventing late relapses. And the AIDS Malignancy Consortium has talked several times about mounting a national study, and the consensus is we don't see enough patients anymore to do a national study. Um, let me turn to another development in therapy, and that relates to the treatment of diffuse large B-cell lymphoma, one of the non-Hodgkin's lymphomas that we see in HIV patients, that's substantially increased. Its incidence has fallen with antiretroviral therapy, but not nearly so dramatically as the brain lymphomas. And we are still seeing substantial numbers of patients with HIV who develop lymphoma. Um, the outcomes are much better in general than they used to be, both for, again, for people with HIV and without HIV. And we've participated and led studies of showing that both autologous and allogeneic transplants um, are often helpful for people with HIV lymphomas, and are often curative. But the new very exciting treatment in lymphoma is our CAR T cells. So these involve so CD19 is a protein that's on the surface of B cells in general, both malignant and normal. And it turns out that you can make a T cell receptor that's chimeric, that includes a piece of an antibody against CD19, so that you can direct that cell to kill CD19 expressing cells. And so what's done for patients is to do a leukapheresis. They get connected to a pheresis machine for several hours, and then the cells get mailed to a lab that, interestingly enough, uses a lentivirus derived from HIV to put the chimeric antigen receptor gene into the patient's T cells and grow them up. And standardly, this has taken about 2 to 4 weeks. Um, and then they mail the cells back to us. If you just infuse these directly into patients, they're not tolerated, they're rejected by the patients. So patients get what's called lymphodepletion, a few days of fairly gentle chemotherapy with fludarabine and cyclophosphamide. Um, and then they get a single IV infusion of the CAR T cells, and there are all kinds of toxicities. We see what's called CRS, cytokine release syndrome, where IL-6 and some other cytokines can get people profoundly ill, and especially early on, they routinely ended up in intensive care. It still happens, but we've gotten much better at managing it. Um, they can also get um, neurologic side effects, which we've also gotten better at managing, but can result in death. Um, but this treatment is often effective for people who have failed every other therapy and would otherwise be going to hospice. So the toxicities we've talked a bit about, the cytokine release syndrome, the neurologic toxicity. Um, it also leads to prolonged cytopenias. So B cells always disappear. Um, for reasons that are not very well understood, it's also common to get neutropenia. And for sure, between the two, there's an increased incidence of infections. The treatment is very expensive. The T cell product, not including any of the physician costs or other management costs, but just to get the bag of gene um, transformed cells costs about $500,000. So major financial toxicity in addition to the other toxicities, although um, we've had pretty good luck getting insurers to cover. Um, the FDA approved 4 different companies making CAR T cell products, all targeting CD19. But it will come as no surprise to this audience that people with HIV were excluded from all the registration trials. So no one knew whether this therapy would work in HIV patients or not. Um, and with that in mind, we undertook we have 2 efforts. One, many of us with patients who failed therapy got them treated with CAR T cells. Insurance companies agreed, or Medicare or Medicaid agreed, and so people were treated off study. And we have a prospective ongoing study now that's just beginning to enroll patients. That hasn't been completed yet, but we recently presented the results of the retrospective study. Um, and the AIDS Malignancy Consortium enlisted the um, Center for International Bone Marrow, the International Bone Marrow Transplant Registry, to get a comparison group. And so what you see in the red line is the survival of patients who were treated during the same period who didn't have HIV and who got CAR T cells for their lymphoma. And the blue line, people who did have HIV. And you can see that people with HIV don't do quite as well as people without HIV, but clearly there are survivors and people who have responded and people who would be otherwise deceased. Um, and the paper should be coming out in the next couple of months. Um, why did the HIV patients fail? There was a higher risk of relapse and it, a little bit of increase in infection, but the main thing was a higher risk of relapse. It's not clear whether that's the biology of the lymphoma or the biology of the T cells that we collected. More to learn, but progress being made, and clearly it's sometimes an effective therapy for lymphoma and HIV patients as well as others. I was going to tell you a patient story, but the patient that we put onto this study did not have a happy ending, and it was painful to review. So to summarize the retrospective study, a little more than a quarter of patients are alive 2 years after therapy. And again, without this intervention, we'd expect that number to be zero. Um, Worse lymphoma control was the issue. There are a variety of issues that may relate to the control comparator that was used here, and in particular, the HIV cohort was much more heavily African American than the control cohort, and there's recently been evidence presented that there is a gene that is commonly mutated in Africans with lymphoma and African Americans with lymphoma that may confer a worse prognosis. How large a role that played, we don't know. Um, lots of questions to be answered. Let me share a few thoughts about KSHV and HHV8. Um, so Kaposi sarcoma um, usually presents in the skin and most commonly in the legs and the feet, but can be on mucosal surfaces. It can be throughout the GI tract. We can see it in the mouth, the hard palate, stomach, intestines. It can also appear in the lungs. KS has been recognized in a variety of different settings. They're all associated with the virus. It was originally recognized in older Jewish Ashkenazi men. That's classic KS. Turns out it's common in the Mediterranean in general. So there are Southern Italian populations, Greek populations, Gulf Arab populations, and North African populations that all have this sort of what's called classic KS. It was next recognized in transplant patients, and like post-transplant lymphomas will sometimes regress when immunosuppression is changed, but really commanded attention when it showed up in AIDS patients. And in AIDS patients, there are also regions of Africa where, unrelated to the HIV, it presents in young men, again, usually in the legs and feet. Um, it seems to be fairly aggressive, often associated with more lymphadenopathy than we see in other settings. Um, and in the early days of HIV, we saw lots of very aggressive KS in HIV patients. The character of the KS that we've seen has gotten gentler in most cases since then. Um, the Unlike the other herpes viruses, KSHV has a seroprevalence that's very different in different populations. So in most of the US and European populations, it's pretty rare that people are KSHV seropositive. And in order to get KS, you need to have the virus. So among HIV patients, it's unusual to see KS in IV drug users. It's much, much more common in men who have sex with men. And the seroprevalence in men who have sex with men seems to be considerably higher than the general population in the US. Originally, it was presumed that it was sexually transmitted through semen, but the virus is found at fairly low levels in semen, but high levels in saliva. And it's thought that salivary transmission is the way it's commonly spread, but there are lots of mysteries here. And with regards to MSM, it's thought, but for all the reasons you can imagine, is very hard to study, that it's the use of saliva as a sexual lubricant and or oral anal sexual practices that are responsible for spread in this group. Although it can be spread by transfusion and organ transplant. At least the transfusion piece is relatively rare. We've actually seen a series of cases in our organ transplant patients where we've seen KSHV that appears to have come from the donor um, appear. Um, just a couple of things to tell those of you who are seeing patients. It's very different than other sarcomas, and I think it would be best if it had never been given that name because sarcomas as cancers are typically amputated, cut out when they appear to be localized, and we continue to see patients who have gotten diagnoses of Kaposi sarcoma and it appears localized in a foot, a toe, whatever. And before we ever see the patient, they've had a toe amputated and sometimes more aggressive surgery than that. At a first approximation, um, I don't think there's ever a role for amputations or aggressive surgery. It's a systemic disease, even when it appears to be localized. And we have some pretty good chemotherapies. We may be getting better chemotherapies, but people shouldn't be going to surgeons for anything other than the biopsy. The other problem that we commonly see with patients. So again, we have people who have pretty good CD4 counts and unmeasurable viral loads who pop up with KS. And half the time, I would say, um, there's a history of topical steroids or a sore back, a sore knee, something that they got steroids injected for, or asthma that were treated with inhaled or systemic steroids. And steroids really are pouring gasoline on the fire in KS, and whenever possible should be avoided. We have many patients who, when they've gotten off steroids, the KS has either stopped progressing or regressed altogether. And I should say that in addition to seeing HIV patients with KS, my clinic now has probably a couple of dozen patients who are men who have sex with men who have repeatedly been HIV tested and are HIV negative but have KS. And in this group, we're seeing um, what's almost always, not always, but almost always confined to the feet or lower legs. It's milder disease, but can be very annoying and difficult to deal with. So it's not restricted to patients with HIV. The bone marrow biopsy, and I want to emphasize that people who are having fevers and cytopenias, even when they don't have peripheral lymphadenopathy, you should consider bone marrow biopsy as part of the workup. And this patient had Hodgkin lymphoma, and Hodgkin lymphoma in HIV patients is about 90% of the time associated with EBV. It's only 20% in non-HIV patients, um, but we're often seeing it in HIV patients with sort of unusual presentations that don't necessarily involve lymphadenopathy, such as is seen in non-HIV patients, and makes people think of Hodgkin's. Hodgkin's is about 7 or 10 times more common in HIV patients. It's usually associated with B symptoms. Marrow involvement is much more common than in the general population. And because of the extensive differential diagnosis, um, it is very common for diagnosis to be delayed such that patients are profoundly ill when they get diagnosed. If they're not too sick, we do a really good job curing them. And this shows the results of an AIDS malignancy consortium trial that Laura helped with, where um, all of the patients achieved remission with the initial treatment, and most people stayed in remission. This is now an old slide, but we're about to report 5-year follow-up. And for sure, if people are in good enough shape that they meet all the criteria to go on a clinical trial, which means you've got to have reasonable renal function, you've got to have good liver function, um, and a good performance status, we're usually curing them. And the problem then with Hodgkin's is the people who get diagnosed so late that they wouldn't have been eligible for a trial, and they don't do very well. And we see some of that at Hopkins, like the patient that I just showed you, but um, in other parts of the world, it's even more troublesome. Um, Samantha Vogt was a fellow with me, and then is now a faculty member in hematology, but she's led an effort in South Africa, um, and got me interested when she was telling me the story that in South Africa, about 20% of people are HIV infected. Um, and the survival by HIV is much worse for HIV patients than for others. And in fact, almost a third of patients weren't getting treated because they were in such poor clinical condition when they were finally diagnosed. And why was diagnosis so difficult? Well, I've told you some of the problems that we see at Hopkins, but in South Africa, these problems are even worse because TB is the leading cause of death in HIV patients in South Africa. And the signs and symptoms, fevers, night sweats, lymphadenopathy, overlap with those of TB. And so it's common for patients to be treated with anti-tuberculous therapy before biopsy is pursued, before there are attempts made to demonstrate that it might be, for example, Hodgkin's. And so we've been interested in the notion that we might facilitate the diagnosis of Hodgkin's by looking for EBV in the blood. And our enthusiasm for the approach really came from work that was done in Hong Kong related to nasopharyngeal carcinoma. So nasopharyngeal carcinoma is always associated with EBV wherever it occurs, but is about 50-fold more common in southern China, in particular in Cantonese and Fukienese speaking populations. And this includes Hong Kong. And these people don't have any evidence of immunodeficiency. They don't succumb to a variety of other infections, but end up with nasopharyngeal carcinoma, in particular in men older than 40. And a large study was done by the group in Hong Kong where they screened 20,000 people. If there was any detectable EBV, they they screened plasma by PCR. If there was any detectable EBV, they brought them back a month later. Initially, about 1 in 20 patients were positive for EBV in the first screen, and when they were screened again, about 300 were still positive, and those people got more serious workups with scans and endoscopy, and 34 were shown to have nasopharyngeal carcinoma, which is a pretty good detection rate for a screen. And uh, and showed that viral DNA could be used as a marker for a tumor. Now, as you might guess, it's much more complicated in HIV patients because the rate of positivity in people who don't have a tumor is much higher. The baseline rate is much higher. I'm going to skip over that. Except to say that we looked at the Hopkins experience with screening for EBV in the clinical microlab and found that you couldn't tell anything by the copy number, that you could have high copy number in people who had no EBV related illness and or had mono and or had any of a dozen different EBV associated disease. When you look in plasma, there's two kinds of viral DNA you can see. You can see DNA packaged in virions, or you can see fragments of DNA released by dying cells, typically tumor cells, and this is what was being seen in nasopharyngeal carcinoma. But you'd like to be able to tell the difference. And it turns out that the DNA in latently infected cells, the viral DNA in latently infected cells, is replicated by the cellular DNA polymerase, which does not work with DNA methyltransferase. And so, I'm sorry, in tumor cells is replicated by the cellular DNA polymerase, which does work with a DNA methyltransferase. So the DNA in latently infected cells is typically heavily methylated, but the DNA in virions is made by the viral DNA polymerase that doesn't work with the DNA methyltransferase and so isn't methylated. And by doing simple assays to see whether the DNA is methylated or not, we think we may be able to distinguish people who have EBV being released from tumor or just have viremia. And the assay that we use is illustrated here. If there's methylated DNA there, it will bind to beads that have a protein that binds methylated DNA. And we can fractionate the DNA then to tell what's methylated, what's not methylated, and measure EBV and the various components of the mixture and get a sense of the fraction of DNA that's methylated. And when we looked at people with nasopharyngeal carcinoma, we always saw highly methylated DNA in their plasma. When we looked at HIV patients who have high levels of EBV in their blood but don't have tumor, we're seeing no methylation. And when we look at people with EBV positive Hodgkin lymphoma, we're consistently seeing high levels of methylation. There are occasional people with EBV negative Hodgkin lymphoma who also have EBV in their plasma, and it's not methylated. So we think there's a possibility that this is a good marker for who's got a tumor or not. We've been collecting lots of specimens in South Africa. The assays have started. We have another big shipment coming in, and actually just came in last week. We expect to be able to answer the question about the utility of the approach in diagnosing Hodgkin's perhaps earlier than we might otherwise. And with that, I'll conclude and thank Laura. And there are many collaborators, but Rena Shan, who's in leads molecular pathology at Hopkins, has been a key collaborator, and Samantha Vogt, who I mentioned, who's been working in South Africa. And the CFAR and the AMC have been absolutely critical in supporting our efforts and in educating me, and I thank all. I'll stop there and take questions.
Well, people are thinking about questions. I was wondering, Rich, what you thought about if any new AIDS defining cancers will ever be named as the
No,
AIDS.
I think, well, so there are probably others here who can speak better to it, but I don't think there's much interest in making anything AIDS defining anymore. I think there's much more interest in what's the CD4 count, what are the details of the immune function. But I think it's become clear that and Richard Moore can probably speak, and maybe others can probably speak better to the point than I can, that it may be that prostate cancer and colon cancer are actually less common, but perhaps associated with different issues and still need to be addressed in the HIV population. But we've known that Hodgkin lymphoma, for example, is more common in HIV. It took a while to recognize that that was the case because um, it wasn't 100-fold increase or 1,000-fold increase like with primary central nervous system lymphoma. And young, otherwise healthy people get Hodgkin's, so it didn't immediately stand out that there was a dramatically increased incidence of HIV. But certainly we've known for 20 years that Hodgkin lymphoma has increased in HIV patients, and there's never been a move to make it an age-defining illness that I'm aware of.
And the aging population also contributes surely to the changing landscape of cancers. Chloe.
Yeah, so thanks for so much for that talk. It was great. I had a question about the people with HIV who were in that prospective study who got the CAR T cell therapy, a retrospective study, I mean. Um, I was wondering if there are any characteristics of the people with HIV, amongst the people with HIV who actually did respond to the CAR T cell therapy. I know you compared it to the people without HIV, but was curious if there was anything that came up amongst those people with HIV.
So it's a great question, and it's the reason the paper hasn't gone off yet. So the data about the HIV patients came from the CIBMTR. So everyone who does transplants or CAR T cells has to report their data to this central registry, and we do that. And again, we had a patient that was reported that contributed to the series, but but it wasn't a study deliberately set up in advance. And so the CIBMTR was not collecting viral load or CD4 counts. So we've been going to AMC sites, many of whom contributed patients, seeing if we can get the details of the people who got the CAR T cells and see if people with CD4 counts less than 100 did less well than people with better CD4 count, sort of thing. But the short answer is we don't know yet.
All right, thank you.
I also had a question um, regarding the CAR T cell therapy patients. I was wondering, given the therapy is immune based and the similarities with lentivirus and the lentivirus is used in HIV, if there's any thought that the environment in which the lymphomas and HIV patients, whether there was immunologic pressure that they escaped, therefore they're less prone, or if there's any thoughts regarding that interplay in the immunology involved that could be explaining the findings.
So there was lots of reluctance by the companies that make CAR T cells originally to accept blood from HIV patients, and there was concern that you might get recombination and have something bad happen. And Again, from the retrospective study, we don't have any details. There are multiple products, each prepared in somewhat different ways per each of the different companies. So, it's still not the, we just don't know.
Thanks.
Anybody else with questions, comments? Well, thank you, Rich, for joining us and putting that together. That was really great overview, and we look forward to hearing from you in a couple more years.
Thank you.
Thank you.
Yeah, next week we'll have cases and Eileen will be back. Thanks, bye.